So what is diabetes? So I'll just briefly begin. So whenever the sugar levels in our body will cross certain limits, and when it crosses, this leading to other organ complications, that is basically diabetes. Now why will it happen, how will it will happen, that we'll be discussing. So what are those sugar levels? Is anyone aware of the cutoffs? Fasting, what is the cutoff? HbA1c, what is the cutoff?
70 to 100.
70 to 100, okay. HbA1c?
6.5.
6.5, yes. So good enough. So any HbA1c more than 6.5, we will label the patient as diabetes. 6.5 male idre, that patient will be having diabetes. Now you should ask me why 6.5, why that number? Or for that matter, fasting. So you need to understand two numbers. One, the cutoff for diagnosis. ನಿಮಗೆ ಡಯಾಬಿಟಿಸ್ ಇದೆ ಅಂತ ಹೇಳಕ್ಕೆ, to tell if you have diabetes, what should be the number. Once you are diabetic, what is the target number? So ಅರ್ಥ ಆಯ್ತಾ ಇದು? So diabetes ಇದೆ ಅಂತ ಹೇಳಕ್ಕೆ HbA1c should be more than 6.5. Fasting sugar, early morning fasting sugar should be more than 126. 2 hours after food sugar should be more than 200. If any one of these criteria satisfies, doctor will be labeling you as diabetic. Okay. Once you are diabetic, you will be diabetic for lifetime. Again, that will also I'll explain. Okay. And once you are diabetic, what are the targets? Targets andre, what should be the levels of sugars you should maintain so that you will not develop other complications in the future. So that will differ. For the targets, generally HbA1c is less than 6.5. Fasting sugar should be somewhere between 80 to 120, and 2 hours after sugar should be between 120 to 180. This will be our target of sugars in a diabetic patient. This is not to diagnose diabetes. This is the targets in diabetic patients. Okay. So again, the thing about targets is it will vary. If a patient is young, I'll be targeting more of strict control, much stricter targets will be there. If the patient is old, having some other heart issues or kidney issues, my targets will be a bit lenient. Solpa male itkotine our targets. So targets is variable, but for the diagnostic criteria will not be variable, it will be same. Okay. So this is about diagnosing diabetes. Now you should ask me, sir, how did you come at the cutoff of 6.5 or 126? Any idea? So why that 6.5 or why 126? Why not 150? Why not 100 for that matter? So it's like this, it's all about retrospective studies. So initially, maybe 50-60 years back, when we collected a group of population having some high sugars and with some complications. So what they found out was, if there was a patient with sugars more than 6.5, that patient's risk of developing complications, let it be retina complications, kidney complications or heart complications, it was found to be high. So it's all about retrospective. It's not that 6.5 ಮೇಲೆ ನಿಮ್ಗೆ ಇದು ಬರುತ್ತೆ ಆ ಥರ. It's not like that. It was found that those patients ಯಾರಿಗೆ retinopathy ಇತ್ತು or patient was having some kidney issues, when we studied their back data, we found out if there was sugar levels for more than 6.5, they had increased risk. Risk probability was more of developing complications in these patients. It's not that ಯಾರಿಗೆ sugar normal ಇರುತ್ತೆ or those with normal sugars will not develop any retina issues or kidney issues. They will develop, but the probability or the risk will be more in those patients with sugars more than 6.5 or 126. That is how we got the targets. Okay, I think this is clear. So what are the types of diabetes you people know? Yes, there are diabetes ಇದೆ. Type 1, type 2, gestational, yes, pancreatic diabetes, and many more genetic related diabetes are there. So that and all, it's not important. What is important is three aspects, most commonly what we see in general population: type 1, type 2, and pancreatic diabetes. Okay, gestational, I think no point in discussing here. Okay, so type 1 and pancreatic. So type 1 is more of genetic based, so it's more commonly seen in younger individuals, mostly 20 years and young. Because of some genetic issue, they develop something called as autoimmunity. Autoimmunity andre, our immune system will start working against our own organs. Let it be thyroid, let it be rheumatoid arthritis, or let it be type 1 diabetes. In type 1 diabetes, our immune system will develop antibodies against our own insulin producing cells in pancreas, because of which patient will be having less of insulin, and patients will end up having high sugars and they will come to us. Pancreatic diabetes andre, because of some pancreatic issue, maybe stone in pancreatitis or alcohol induced pancreatitis or some genetic condition induced pancreatitis, pancreas capacity, insulin utpatti mado capacity will come down. So then sugars will go up. These are two aspects. Main aspect, topic of discussion today, that is type 2 diabetes mellitus. So how does it start, type 2 diabetes mellitus? Yargadre an idea? Do you have any idea how does type 2 start? Stress, okay. Lifestyle, yes. Lifestyle andre, I'm assuming sleep, diet, exercise, yes. Stress, lifestyle, and stress.
Obesity.
Okay. Obesity, yes. Okay, so you people have some basic idea. So before we go into the pathophysiology, so I want you to understand how insulin works in the body. So let's assume this is a cell, muscle cell or heart cell or brain cell. That is the door, and the corridor is the blood circulation. Fine. So I eat some food, though my digestive system digests, so the glucose level is absorbed into the blood circulation. So there is, after my food intake, there is glucose in the corridor. So glucose, for effective utilization, it has to come into the cell. Let it be muscle if I'm working out, if I'm thinking my brain, if my heart is pumping to my heart, okay? It has to enter through the door. So to enter through the door, we need a key to open the door, right? That key is insulin, simple, okay? So let's